Hi class, this is Emma Breeden and we are going to have a lecture on chapter 4 in your textbook, but it is about anxiety disorders, trauma and stress related disorders, and obsessive compulsive and related disorders. Obviously, this topic we could talk about for hours, so I'm going to try and just hit the highlights of various disorders. And one thing I'm hoping you guys can keep in mind is rather than just memorize the symptoms and causes and treatment of the disorder, I really want you to think about what about each disorder is distinctive and how is it different from the other disorders. So, for example, there's many different anxiety disorders, but what makes them different that there's not just one anxiety disorder? And that will help you definitely for test purposes, but even out in real life, going, oh, that person does display this symptom, but not this, although they're both anxious. Which one is OCD, and which one is panic disorder, and which one is generalized anxiety disorder, and so on. So that's enough about that. I've already just sucked up too much of your time. Let's carry on. So we're going to be talking, first of all, we have to talk about what anxiety is. And first of all, anxiety is a normal emotion for everyone. Hopefully you all feel anxiety before a test because anxiety is what motivates us. Normal amounts of anxiety, motivate us to study for a test, motivate us to prepare for an interview, and so forth. So the whole term of anxiety, it's a future-oriented mood state. People who have anxiety, they're actually future-oriented. They're not living in the here and now, and they're not thinking about the past either. So, anxiety is apprehension about the future danger or a misfortune, being concerned about the future. Anxiety can have physical symptoms, and there's different kinds of physical symptoms between fear and anxiety, so we're going to focus on anxiety. A physical symptom of anxiety could be tension, muscle tension. It's very common for people who suffer from anxiety to have shoulder tenseness in their shoulders, headaches, neck aches. It's kind of like a muscle tension, like they don't relax. They will not necessarily have a palpitating heart or be sweating, but they definitely have this tension that's in the core of their bodies. It's characterized by a negative affect, and what that means is they're kind of muted. There could be a funny situation and people struggling with anxiety won't laugh. It's usually because they're in their head. They're not really living in the here and now. Anxiety can lead to avoidance of situations that provoke fear. So, for example, if someone doesn't like spiders, then they'll be future oriented and do things to avoid being near spiders. And we'll talk about that kind of incident in a little bit. So just so you know, anxiety and fear are normal emotional states. We should be experiencing those maybe even daily. However, they can become abnormal, and that's what we're going to focus on today. So fear, which I mentioned briefly but didn't really talk about, fear is in the present. So right now I'm not feeling any type of anxiety or fear. But if someone were to jump out and startle me, I would have fear. Fear is always going to be an immediate fight or flight response to danger or a threat. Okay, so fear is of that fight or flight when your autonomic and sympathetic nervous system just kicks in and tells your heart to start beating, you start sweating, you start breathing rapidly, and digestion stops. Body temperature rises and you're getting ready to fight. So if you're under fear, if you're having a fear experience, it's going to be that fight or flight, autonomic, sympathetic nervous system getting triggered. Now, people who experience fear of a certain thing will avoid feeling this way. So, for example, if I'm afraid of bridges or driving on bridges, I'm going to avoid driving on bridges so I don't get the unpleasant experience of fear. Negative affect, again, it's emotions and affect are distunted. You won't see someone smiling or crying. They seem, once again, very within themselves and reflective on what's going on inside their body versus what's going on externally. So anxiety and fear kind of go together, but they are two different components. Now, we talked about normal, and it's normal to be anxious and it's normal to be fearful. However, a couple things can make it abnormal and then become disordered or an anxiety disorder. So, first of all, if something's pervasive and persistent, of anxiety or fear, meaning it won't go away no matter what you try, and it's pervasive, maybe entering into different areas of your life. It's excessive and you avoid and have escape tendencies. So maybe I won't go visit my mother because I have to drive on a bridge. So that's excessive avoidance or escapism. It's pervasive and persistent. It doesn't go away, and it has to cause significant distress or impairment. So when we talk about abnormal or pathological anxiety, it has to have these three components. It has to be also illogical anxiety, pervasive and persistent symptoms, excessive avoidance and escape tendencies, and it has to cause the distress and or impairment on an individual. Now, I want to talk a little bit about panic attacks, because panic attacks can happen with any anxiety disorder. Now, there is panic disorder in and itself, but anxious people tend to have panic attacks. And I kind of want to describe what that is. Just so you know, everybody is going to have a panic attack, whether you're struggling with psychological problems or not. So men tend to have about 2 in a lifetime, and women up to 5 in a lifetime. And that's not many if you think you have 1 every 5 years or 1 every 15 years for women. So a panic attack is an abrupt experience of intense fear. So it's an acute onset. It just hits you. It's mostly physical symptoms such as heart palpitations, rapid heartbeat, chest pains, difficulty breathing, dizziness, sweating, chills, heat sensations. Some people may actually not be able to speak and get to the point where they pass out. Cognitive symptoms is basically a fear because you don't know what's going on and you can't control your body anymore, especially if you're going to pass out. So the cognitive symptoms is fear and just like a lack of control and very discomforting psychologically. Now, there's 2 types of panic attacks. There's unexpected, which another term for that is cued. I'm sorry. There's expected, which is cued, or unexpected, which is uncued. Expected panic attacks is, say, when you go speak in front of a class, you start to become nervous, anxious, and fearful, and then your body autonomic nervous system triggers off to a fight or flight where you have a panic attack. That would be expected. You never have them except under certain situations. That's cued. It's very common for people in social situations who every other time of their life they don't have panic attacks. We'll have them in a social situation. Then there's the unexpected, uncued. Now these are kind of tricky. These are just, you never know when you're going to get your panic attack. You could just be sitting there at home watching TV and bam, your heart starts racing, chest pains, dizziness, sweating, and you can't control it and you can't stop it. And those are a little more frightening because people don't know when they're going to occur again. So there's different types. So a person could have cued or expected panic attacks. They could have uncued panic attacks, or they could have both. They know they're going to have some in some situations, but sometimes they have them randomly also. And then there's internal and external cues when we have expected panic attacks. So an external cue is pretty simple. It's like I said, public speaking. The situation outside you causes you to have a panic attack. But you could also have internal cues. And internal cues is like, say you're working out at the gym, you're getting hot, you're getting sweaty, your chest, your heart starts to beat fast, your breathing becomes shallow. Those little cues can actually trigger and send you into a full-fledged panic attack. So anytime when people would get elevated blood pressure and lack of breath, those are internal cues, bodily cues that can actually trigger and send your sympathetic nervous system into a full-blown panic attack. Now, once again, I'm not talking about panic disorder yet, but obviously panic disorder people have panic attacks. But I just want everybody to know that panic attacks are a normal experience, a few in a lifetime. However, most people with anxiety disorders have a lot of panic attacks. Before we start talking about each anxiety disorder, I want to talk about comorbidity. Co meaning like together, like cohabitating, comorbidity, and that is having more than one diagnosis at a time. So it's not the exception, it's the rule for the most part. So it's really common across the anxiety disorders. So you're not just going to have generalized anxiety disorder, you're probably going to have 2 or 3 other anxiety disorders and maybe some other type of disorders. Major depression is the most common secondary diagnosis. So if you're diagnosed with an anxiety disorder, there's a high likelihood that you could be or may be struggling with major depression also. About 50% have 2 or more secondary diagnoses. Okay. So when we talk about comorbidity, just know that throughout the whole course this semester, most disorders are comorbid with another disorder. So anxiety seems to go hand in hand with depression, substance abuse will go with other ones, personality disorders will go with other ones, and so forth. So let's continue. Here's a few of the anxiety disorders we're going to talk, and we're not going to talk about all of them today just because of lack of time. But I'm going to focus on generalized anxiety disorder, panic disorder, agoraphobia, social anxiety disorder, and phobias. I make a little comment on selective mutism and separation anxiety, but just very briefly in passing. Once again, this lecture is just going to be some key points. You definitely will still need to read the book, unfortunately, because there's just so much to know, but I'm going to definitely try to highlight some things for you. Okay, number 1, generalized anxiety disorder, also known as GAD, generalized anxiety disorder. It's chronic worrying. It's excessive, uncontrollable anxiousness, apprehension, and worry about many different areas in your life. And it has to go on for 6 months. It's accompanied with muscle tension, restlessness, sleep problems, irritability, concentration difficulties, and fatigue. So what this looks like in a person, it's a person who's constantly worrying about various things. It's not like they have a job evaluation coming up and they're worrying about their job evaluation. That would be normative. These are people who all day are like, oh my gosh, I wonder what's going to be at work tomorrow. How's that meeting going to go? Oh my gosh, my relationships. I haven't seen so-and-so. I haven't called so-and-so. Oh my gosh, so-and-so hasn't texted me. What's going on there? Oh my gosh, I have a headache. I must have a brain cancer. I mean, they're all the time just worrying. And it's usually nothing. It's about they're worrying about day-to-day events, and their worrying is not proactive in any way and motivate them to prepare for anything. These are the people that sit there at night and analyze everything that just happened, and they're already analyzing everything that's going to happen the next day and processing it. And what happens is they're not living in the here and now. When you go to talk to someone who's struggling with generalized anxiety disorder, they become very irritable and snappy because you've just interrupted all their worrying in their head. And then they worry about that. So, I want to go back a little bit. People with this disorder, these are also usually list makers, and they love completing lists, starting new lists, and there's always processing what they have to do next because they're worried. Once again, this sounds kind of good in a way because at least they're trying to be proactive in their life, but unfortunately their worrying becomes impairing because they have sleep problems, concentration problems, and so forth. So statistics, it affects about 3% of the general population. It is a female disorder, and I'll say that a lot. When I say it's a female disorder, it doesn't mean men don't get it, but it's a 2-to-1 ratio. That means for every male that gets it, 2 does. So it's more common amongst females. Onset is insidious, meaning slow. It begins in early adulthood or maybe in adolescence. It's very prevalent among the elderly, so you'll know people, maybe your grandparents were pretty awesome and pretty solid people and didn't have any anxiety, and all of a sudden as they went into retirement and started to age, you'll notice that they're very anxious about a lot of things. This disorder tends to run in families. That doesn't mean it's hereditary, but we'll see it that if one parent has it, another parent will have it, the grandparents will have it, and so forth. Okay, now, like I said, we're going very brief on these. So treatment. Treatment of GAD is generally weak, and it doesn't matter what type of treatment you do. So when I mean weak is I mean the prognosis is not good. I don't want to say it's poor, but it's guarded at best. When you are dealing with someone's thought processes and they're worrying all the time, and you're trying to get them to teach them different ways of thinking, it's hard to think differently than what we've been doing. So the psychological intervention of treatment of GAD would be cognitive behavioral therapy, basically targeting the maladaptive thinking and replacing it and identifying it and replacing it with proactive thinking. The pharmaceuticals that would be used with people with GAD would be benzodiazepines, which are the most prescribed, which helps with the GABA and it decreases anxiety. And we can couple these with antidepressants. Now, I'll come back to that medication in a little bit. Actually, I'll say one thing. The medications may help the symptoms, not the cause, but the symptoms of the disorder. However, once the medications are stopped, the symptoms will come back stronger than they were before, meaning the anxiety is going to be stronger than before. Then there's meditation, and meditation is a way of relaxing, a good way to try to control the mind and the body. And then there's combined treatments. Whenever we talk about combined treatments, it means combining medication with psychological intervention. So we know acute, if we're dealing with generalized anxiety on the short term, we know that medications are going to work fast because they're going to take away the symptoms. But what we notice in the long term, medication is not very successful, and actually psychological interventions such as cognitive behavioral therapy becomes much more conducive into treating anxiety, because at least they're learning the ways to cope and change their thinking habits, which medications just mask the disorder. They don't treat the disorder. So now we're going to move into panic disorder. So panic disorder is, we talked about panic attacks before, but it's experience of unexpected panic attacks, false alarms. So panic disorder is when you have many. What happens with people with panic disorder is they start to worry and fear about another panic attack. So they have their first panic attack, probably because they're already anxious people, and then they start worrying about their next attack. So they become more anxious, which then triggers another attack, and on and on. So to be diagnosed with panic disorder, you have to have so many attacks within a 30-day period, or so many attacks within 6 months. And that number is always changing and is kind of subjective. But obviously, if there's impairment and distress, think about it. If you become worrisome about having a panic attack in class, you may start missing class, because that's what people with anxiety do. They avoid and escape. So therefore, it could affect their grades and their academic career. Now, many people who struggle with panic disorder also develop agoraphobia. Agoraphobia. So agoraphobia kind of goes hand in hand with panic disorder. Obviously, it's got phobia on the end, so it is a fear of a particular situation or object. So agoraphobia is fear of being in places which would be difficult to escape or get help in the event of unpleasant physical symptoms. So basically, agoraphobia is a fear of being out in the market. Agoria means marketplace. So basically, kind of a fear of being in some kind of crowded outdoor kind of place, and they occur together. They can occur independently. Someone can have agoraphobia without panic disorder. Some people can have panic disorder without agoraphobia, but there is a definite strong correlation between the two orders, and they will increase the likelihood of the other one occurring. It's not a cause and effect, but they just kind of go hand in hand. So what happens is these people, they start to become reclusive, stay inside, very afraid to go out. But what will happen is when it comes time to go out, or say they want to go to their friend's house for Christmas or Thanksgiving, that can just send them so skyrocketing in anxiety that they'll just have panic attack after panic attack and they won't go out. So here's some general facts about panic disorder. It affects about 2.7 of the general population. Onset is acute, usually between the ages of 20 and 24 years of age, which is college age and entering into young adulthood. 66% of individuals who have panic disorder with agoraphobia are female. This is, once again, tends to be a little bit more of a female disorder, meaning that women suffer from it significantly more than men. Not that men don't suffer, men suffer, but just not as much. Definitely want to pay attention to the male and female who suffers more from what disorders, because it does help with diagnosing, and it kind of can distinguish certain disorders from each other. Okay, so there's a lot of times people who have panic disorder, there's some other things they could have, is nocturnal panic attacks during non-REM sleep. So they will wake up, well, not wake up because they won't, but they will look like they're awake having a panic attack, almost like a night terror kind of situation. And they also do experience sleep paralysis. People who have panic disorder, they wake up and they feel like someone's in the room and trying to hurt them, but they're paralyzed. So those two components are associated with panic disorder. When it comes to treatment, usually a medical doctor would prescribe SSRIs, Prozac and Paxil, which we talked about in Chapter 2, and benzodiazepines, which we also talked about in Chapter 2. But once again, they're just treating the symptom. They are not treating the cause of panic disorder. Unlike generalized anxiety disorder, there is psychological treatments that are highly effective. Cognitive behavioral therapy is highly effective in permanently, or at least for a significant amount of time, alleviating the symptoms of panic disorder, actually treating it rather than just masking symptoms. So let's talk about it a little bit, because I know a lot of people struggle with panic disorder. So panic control treatment, known as PCT, it is cognitive behavioral therapy, but it's got its own name because it's a certain procedure. Basically, you are purposely triggering panic sensations so the person can build tolerance and bring themselves down. So what we would do if someone had panic attacks, we would try to induce a panic attack. So I would have them drink a caffeinated beverage. I would have them run in place with a straw in their mouth, and all they could breathe through is the straw, so it would get shallow breath. The running would create a high heart rate, and I would then spin them around until they got dizzy, and this would do an internal cue to a panic attack. At that point, I would be with them, and as they try to biologically and psychologically control, I would mentor them through the process of calming down. It's the best long-term outcome out there. There's no evidence that using medication with this kind of cognitive behavioral therapy would produce better outcomes. Very, very good treatment in alleviating panic disorder for years and years. Obviously, you'll be maybe working on some lifestyle changes with the person. Maybe they need to decrease caffeine, period, decrease smoking, other different key things, but very effective form of treatment. So let's talk about phobias. Phobias are pretty common also. They are an anxiety disorder. Its defining feature is extreme. I'm not talking like you don't like a spider near you and you feel uncomfortable. I'm talking extreme. Like you will have a tantrum if you can't get away from whatever the situation or object is. It's an extreme irrational, meaning there's no reason to be fearful of it, of a certain object or situation. People will go to great lengths to avoid phobia situations or objects. Most people, they know it's not normative. They know it's not healthy. Most people recognize that the fear and avoidances are unreasonable, and it interferes with one's ability to function. So Some of you have had me in class before, and you know that I do have a phobia, a pretty irrational, extreme phobia that I do to go to great lengths to avoid. I have gone through treatment, and I'm getting better. I need a little tune up here and there, but and it does mark my ability to function at times. So, bridges. I do not drive on bridges well. So I can do it now. There was many years I would not, and I would go to great lengths to avoid any bridge, and not just bridges like San Francisco Golden Gate, but any type of high structure. So living in Southern California, where the freeways are going up in the air with these gigantic on ramps and off ramps, have been very trying for me, and so I have a phobia. Once again, females, haha, it's a female disorder. Once again, females are overrepresented, meaning like a 2-to-1 ratio. For every male, 2 females are inflicted with this disorder. It affects about 12% of the population, so it is a very common disorder. That's a high number. Phobias can run a chronic course, meaning they will last for a lifetime if not intervened on through treatment. And just so you know, for phobias, in case you know anybody who has a phobia is every time you avoid the phobia, the situation that causes fear and anxiety, it strengthens the phobia, and it can actually make it worse, and that you generalize it to other issues. Let's carry on though. Okay, there's a lot of different causes of phobias. There's direct experience, so I will tell you what happened with me is I was not afraid of bridges, and then when I was in college, I was driving on Lake Shasta Bridge, coming back from Oregon into California, and it was snowing and icy out there, and I was had a big load. I had an old truck, and my car skid out, and I hit the guardrail on Lake Shasta Bridge, and the car almost went over. And it's a very high drop if you don't know that bridge. Terrifying. So after that experience, I then did not like driving on 2-lane bridges and freeways that are high up in the air. So that wasn't a direct experience that caused my phobia. Some people just have like an evolutionary vulnerability or a biological vulnerability. Some people have been traumatized by conditioning. If you think about little Albert, baby Albert from chapter 2 or from your Psych 100 classes, some people can be conditioned, classically conditioned, to have a traumatic experience to what was originally neutral but not anymore. Prepared phobias, or we have a prepared learning kind of thing. So some phobias are somewhat natural. I don't want to say that they're good, but snakes, the dark. Some people who have that irrational, when it gets irrational fear of the dark, they believe it's prepared learned, meaning that we're kind of pre-wired to be fearful of some situations due to our history in humans and human history. Meaning snakes we used to live out in the wild, and snakes were a threat. Creatures come out at night, therefore some people are afraid of the dark. Those are prepared learningness phobias. Psychological treatments, extremely effective. Cognitive behavioral therapies, it's exposure. So the whole point is you need to expose the person to what they're scared of, and you don't do it abruptly. You would very slowly do a systematic desensitization. You would look at what scares the person, try to get them to create a hierarchy of when it affects them the most, and then slowly expose them to what it is. So to be clear on me, I am not afraid of heights at all. I could jump off a bridge. I can run on a bridge. It's driving on a bridge. But I could tell you, just thinking about driving on a bridge causes anxiety. Um, Looking at bridges causes anxiety. Being a passenger in a car when someone else is driving is pretty high anxiety for me, with the highest anxiety being driving on the bridge myself. So for me, I would want to work up that hierarchy until I'm able to drive on a bridge. And exposure is critical, meaning I would need to do it as much as possible. As soon as I stop driving on bridges again, the phobia can kind of seep back in. So I want to make sure on a regular basis, once I'm able to drive on them, that I keep doing it so I don't have that fear and alarm to them, that they almost become second nature. Okay, social anxiety disorder, also known as social phobia. Okay, so social anxiety disorder, which is a social phobia, is extreme fear or discomfort in social or performance situations. For those people who hate public speaking, that may be okay to not feel uncomfortable. But if you have extreme fear or discomfort, physically or psychologically, then you might have social anxiety disorder. It can be marked by interfere with one's ability to function, meaning you do not want to talk in front of the class. Maybe you don't want to come into a classroom late because you're afraid everybody be staring with you. You don't like group activities. These people will avoid social situations or endure them with great distress. There's some people who are only performance subtype. That means public speaking. That means they're okay every day interacting with people and they don't feel anxious. But when they have to public speak, it's overwhelming for them. And it's a social anxiety disorder subtype. It is, like I said, social anxiety disorder is a synonym for social phobia. Now, this disorder is a little different. It affects a large population, again, 12%. But please note, it doesn't have that great divide in males and females. Females is only slightly greater. There's only so maybe it's a 51% females and 49% males. So they're almost equal. This is the first time in this category of anxiety disorders that we've seen this. Its onset is usually during adolescence, can start earlier. The peak age of onset, meaning when most people are diagnosed, is age 13. So for the first time, it's still, I don't want to say it's a female disorder. I'm going to say that it's equally distributed. Okay, causes. So once again, you have the biological causes, evolutionary causes, learning experience causes. They all combine. And when you read your text, you'll see there's so many different causes. Psychological treatment can be very effective. No medication needed at all. Cognitive behavioral therapy. You need to do what makes you uncomfortable. You need to change your thinking about it and do the behavior over and over again. So if it's public speaking, you need to public speak. Every time you avoid public speaking and that anxiety, it actually feeds the phobia more, so it becomes bigger and more profound next time. Group treatment is great. Think about it. If the one thing you have is social anxiety, let's put you in some group therapy, because it's gonna put you in people who are also experiencing the same thing in together. There you can work as a group, working on the different thoughts and behaviors that can help you. Highly effective. Very treatable anxiety disorder. Very treatable. No medication needed. Some doctors will give you pills. They will, because that's what medical doctors do and psychiatrists. But just know it's very effectively treated with psychological treatments. The medical treatment you can do, like I said, the SSRIs. You can use beta blockers or benzodiazepines, but as I said before, it does mask the symptoms. Relapse rates are high following medication discontinuance. So once you stop using the medication, any social anxiety that you used to experience will come back, probably higher than ever before. Okay, I also want to talk about separation anxiety very briefly. Separation anxiety disorder is characterized by an unrealistic and persistent worry that something will happen to self or loved one when apart. Like, for example, when someone doesn't show up on time, they're a minute late, you automatically think they've been in an accident, kidnapped, or whatever. They also have anxiety about leaving a loved one. 4% of children meet the criteria, 6 for adults. What I wanted to comment on and why I brought this up is, a lot of people talk about children having separation anxiety. Please know that separation anxiety is normal for younger children, and I mean like toddlers and preschoolers. If a child did not show separation anxiety, I would have concern. So really, the thing you need to know about an individual when looking or determining if it is separation anxiety would be age. So for example, if I dropped off a 3-year-old or a 2-year-old at daycare for say 3 hours, and they go there every day and they cry when they separate from me, I would call that normal separation. It would not be an anxiety disorder. Now, if I were to drop off a 5 to 6-year-old in the same situation, that child should have the ability to separate and have an identity of their own and feel comfortable with it developmentally. Therefore, that child you would diagnose with separation anxiety disorder. They need to, you have to look at the developmental component of the situation. Okay, we're going to move into, we're leaving anxiety disorders right now, and we're moving into trauma and stressor related disorders. I think we're just going to focus on PTSD. I may briefly talk about acute stress disorder. I don't believe I'm going to talk about adjustment disorder or attachment disorders. PTSD is the most severe of this group. Anyways, these groups, they used to be in anxiety disorders. The DSM-5 made a new classification and separated them out and said, you know what? These have a different causation, and they look, although they do have that anxiety component, they look a little different. So we're going to give them their own category, and this is their very interesting name, is trauma and stress related disorders. Such a weird category. So we are going to focus on PTSD, which is post-traumatic stress disorder. Post-traumatic stress disorder. So overview, first of all, the person has had to have had a trauma. They have had to had a trauma. Now, trauma is subjective. So obviously some obvious things are rape, war, assault. Those things obviously are a trauma, but there's some things that people may find traumatic, like divorce, getting married, a breakup, that can be traumatic, and then they have these symptoms that fall after them. So, re-experiencing the event, which means memories, obtrusive memories coming into your mind, like you're just sitting there in class and you just keep thinking about little memories, just keep popping into your mind about the unpleasant trauma. Nightmares. These people who suffer from PTSD are exhausted because what they do all day is try to block memories out. That's what they do. So when they go to bed at night, they have nightmares because the mind needs to still process those issues. And then they don't sleep. Avoidance. They will avoid anything that will remind them of the situation or the trauma. So say if someone was attacked on campus at school, they will avoid campus. They may avoid all campuses because it will trigger the re-experiencing memories and nightmares. These people tend to be emotionally numb and distant. They seem to have a lot of interpersonal problems. They are very agitated and irritable. Just like with anxiety, they have a lot going on in their mind. And a lot of energy is trying to avoid the trauma, the thoughts of the trauma, the images of the trauma, the places of the trauma. And that's where a lot of their psychological energy goes. So they become very agitated with people. They also startle very easily. Very easily. PTSD is when these type of symptoms persist for 1 month or more. So for example, say you were on campus and someone jumped you and you were assaulted and they took your money. Now, of course, you're not going to feel too comfortable going into school and you're going to have re-experiencing memories. Now, if that's happening more and more and more as time goes on, you could be developing PTSD. If you're having those experiences the days after, the first week after, the second week after, and then it starts to dwindle away and your sleep becomes better and images aren't popping into your mind anymore, then that's a normal reaction. So PTSD is diagnosed after a trauma when the reaction persists too long. And actually, the longer these symptoms go on, the worse they get. There's different types of PTSD. It's usually to do with onset. So acute means it's diagnosed 1 to 3 months past trauma. So acute means they should have kind of gotten over everything by this time and they haven't. Chronic means it's diagnosed 3 months post-trauma. So it's going to be chronic and ongoing. Delayed onset is very interesting. It's onset 6 months or more post-trauma. So maybe you had somebody who the trauma were mugged, and then 6 months later is when all the symptomology came up. It's almost like it was put on hold until the person was able to process it. Acute stress disorder is not PTSD. Acute stress disorder is PTSD-ish immediately post-trauma for up to 1 month. So it's that 1 month when you should be having, it's almost like a normative thing, and only if it's impairing your life would we call it acute stress disorder. So causes of PTSD, intensity of the trauma and one's reaction to it. So once again, it's subjective. It's not a clinician or anybody's opinion on if it's traumatic or not. It's whatever that person experienced. They can have learned alarms from the trauma and have conditioning and observational learning. There is a biological vulnerability for PTSD, a diathesis, an uncontrollable. A lot of people who have PTSD feel very uncontrollable and unpredictable in their lives before the trauma, and that seems to increase the chances of developing the disorder. We know that social support post-trauma reduces risk. So if somebody who's gone through a trauma does not have a good social support and does not get the attention they need, it increases the likelihood that an individual develop PTSD. PTSD. So, treatment. Cognitive behavioral therapy, as we keep saying, but please understand that every time it's different. You're going to want to do flooding. Flooding, which is gradually to masked imaginal exposure. You're going to have the person think, talk, and imagine the trauma over and over and over again. You need to have them develop a narrative of traumatic event to process the understanding. You have to remember these people have taken all their energy physically and psychologically to avoid thinking about this. So you're asking them to do something that's going to be very uncomfortable for them. They even have simulators now that can take people back to war and put them back in that environment so they could process it. You need to challenge cognitively the maladaptive beliefs they have in the world. They start believing that the world's very unsafe and that people are unsafe and everybody's just out to get them. They're not psychotic. People with PTSD can become psychotic if it's extreme. But in general, they just have some maladaptive beliefs about what's going on. Medication. A lot of people, doctors of course, are using medications for anxiety and panic. They're going to use selective serotonin reuptake inhibitors, or they're going to be using benzodiazepines, just like with any other anxiety disorder, although we're in a new category. So some of the main symptoms of the PTSD will be numbing of emotions, flashbacks or memories popping into their mind, nightmares, and they're going to have an increased startled response. And what that means, startled response, is if you're one of those people who just startle easy, that's an increased startled response to stimuli. If you're sitting at home reading a book and you know other people are home and then they enter your room and you jump up and scream, that's an increased startled response. Okay. Another classification, we're going to spend most of this rest of the time talking about OCD, but there's related disorders to OCD. So another category, the DSM-5 decided, guess what? OCD is not an anxiety disorder anymore. We are going to create a whole new classification, and we're going to clump some other disorders in there, and we're going to call it obsessive compulsive and related disorders. They are lumped together because they have all the different disorders in this group have obsessive thoughts or compulsions. So some will have both, some will just have obsessions, some will just have compulsions. Some disorders in this category is OCD, which we're going to spend most of the time talking about right now, hoarding, which we'll talk barely about, body dysmorphic I'll touch on maybe very briefly, trichotillomania, which is hair pulling out, we'll just mention in passing also. So we're going to focus on OCD. OCD is big one, and if I say big one, you're going to see that little sucker on the test. So it's a very complicated disorder. We make a lot of fun of it, but it's actually very debilitating So, the defining features, first of all, is they got to have two components. They have to have obsessions and compulsions. Obsessions are intrusive. They just pop in your head. Nonsensical. Thoughts and images or urges. Intrusive, nonsensical thoughts, images, or urges. These obsessions cause anxiety. The way to decrease anxiety is these compulsions. Their thoughts or actions to neutralize the anxiety. Their thoughts or actions to neutralize the anxiety. People get stuck in a vicious cycle of obsessions and compulsions. Some of the most common compulsions you'll see is washing. Washing is a ritual for the obsession of contamination. So if someone feels they're contaminated, they will wash. Some people who checking rituals tend to have an aggressive or sexual obsession to them. So people who have inappropriate, aggressive, or inappropriate sexual obsessions seem to check a lot. People who need symmetry, have a lot of obsessions with symmetry, will need to rearrange things or repeat rituals over and over again. So I kind of want to go back. Now, one of the components that you'll see in your book is they have to spend a certain amount of time doing these compulsions, and it has to interfere with your life. So some of you are like, oh man, I'm a germaphobe and I like to wash my hands. Yes, great. You probably don't have OCD. OCD means you'll be spending at least an hour or more. I think it's 2 hours actually, 2 hours a day doing these rituals, and these rituals have to disrupt your life, meaning you're late to you can't leave for class because you haven't washed your hands 3 times with certain type of soap and it didn't feel right. People with OCD have a lot about things feeling right, so they'll do their rituals, and if someone interrupts their rituals or it just didn't feel right, they start over again. Just so we make this clear, they know what they're doing is irrational. People, well, let's kind of go on because we'll get there. Oh, I went the wrong way. Okay, so statistics, it's a rare disorder. It's only 2%. Schizophrenia is one of the lowest disorders, and that's 1%. So OCD is 2% of the general population. And we always say everybody has it, and they don't. They don't meet the qualifiers. It's not disrupting their life. They may be anal retentive, and they may like things a certain way, but they're not OCD. They could be OCPD, which is another disorder. But back to this. Equal gender distribution. Equal gender distribution. This is not a male nor a female disorder. Okay? Onset is in early adolescence or young adulthood, and it can be found in childhood. It tends to be chronic. It has an insidious onset that occurs in early adolescence or young adulthood. The disorder itself is chronic. I do want to note that it has comorbidity with many disorders. It's very common for people suffering from OCD to have severe generalized anxiety disorder, to have panic attacks, and to have major depression. A lot of times, people with obsessive compulsive disorder, if they're not able to perform their rituals, whether in their head or exteriorly, they will go into a full panic attack. I call them meltdowns. I keep using this word rituals. Rituals are actions or thoughts that an individual uses to reduce anxiety. It's that compulsion part, the compulsion. Okay. A lot of times people, they believe that bad things will happen if they don't do their compulsions. So for example, a lot of people will check things, and they believe if they need to check or in order to ward off an imagined, not real, not even a realistic danger, but an imagined disaster. Now, some causes of OCD, you're going to have that genetic predisposition, early life experiences, cognitive thoughts, and so forth. But, learning. These people believe that the world is a very dangerous and unacceptable place. They also learn that some of their thoughts are dangerous and unacceptable. They usually learn this. You'll see that people who come from very religious families tend to have a higher rate of OCD than non-religious people, because religion unfortunately sometimes tells people that natural thoughts of aggression and sexuality are inappropriate or unacceptable. So as a way to atone for that, that's where their compulsions come out. Now, thought action fusion is something that I definitely want you to know about. It's usually shows up in the beginning of OCD, and they start to think the thought is similar to the action. Thinking something will make it more likely to happen. Okay? Thinking something will make it more likely to happen. And this is very common in childhood. Children think this way. They think, oh, I thought it, now it's going to happen. So, if a young child has thoughts about hating her younger brother and wishing he would die, the child could become very anxious about these thoughts, because they have developed the idea that if anything really happened to the younger brother, it would be their fault. What you'll see happen a lot is, this is very common in families, you'll have an older child who's doing okay. A new sibling comes. It's very common for an older child to not like the new sibling. They may think to themselves, God, I wish they were dead. I hate them. I wish they were never born. And then, of course, children get sick. So the younger child gets sick. The older child now thinks, oh my God, they got sick. What I think will really happen. And so that's when all those kind of weird obsession thoughts and rituals start kind of breeding themselves. So you will see children as early as like 7 or 8 be diagnosed once autism is ruled out of these issues. Okay, treatment, drugs. Once again, doctors love their drugs. So biological treatments like SSRIs can benefit up to 60% of patients. But once again, as soon as you take away the medication, relapse will occur and the symptoms will come back twofolds. So although 60% of people with this disorder will have their obsessions and compulsions decrease, it's going to come back. There's psychosurgery, which is kind of like a laser lobotomy in a certain part of the brain, and it's used in extreme cases, because there is some people who can't even get dressed in the morning because they are spending the whole time, hours a day, washing, showering, brushing their hair, floss, wash, and they have to start over again because it didn't feel right. And these people, they hold out in their house. I might even post some case studies online. This disorder is very debilitating. We always make fun of it, make it sound attractive and cute or quirky. It's not. It can basically, a person's life could become obsessions and compulsions during every one of their waking hours. It is a very painful disorder. So psychological treatment. We have something, and we have something that works. Cognitive behavioral therapy is most effective. It's got a name. It's called ERP, Exposure and Response Prevention. Exposure and response prevention. So we want to expose them to whatever makes them anxious and prevent the ritual, the compulsion. ERP, exposure and ritual prevention. So if someone had contamination, obsessions, and compulsions of hand washing, we would make them touch the door. We would wait a few minutes. We wouldn't let them do it. They will get very anxious and have what I like to say is a meltdown, which is like a full-fledged tantrum. They may be banging their head against the wall, crying, screaming, sweating, going into a panic attack, and then let them wash their hands after that. We may let them say some blasphemous phrases or think inappropriate thoughts and not engage in a prayer afterwards. Combining medication does not help the CBT because the medication will alleviate the anxiety. We need them to feel that anxiety to push through it. And this learn that life, they can push through the anxiety and not give into it. Whenever you give into an anxiety with a compulsion or trying to avoid it, it grows stronger. So the only way to decrease the anxiety, that feeling, that emotion, is to actually experience it and take its power away. And that's what we need to do with ERP. Now, people who are suffering from OCD can do amazingly well with ERP. I'm talking daily treatment for 15 weeks, and they could have all their symptomology gone for years. It's very effective, almost 90% effective. Very good. Okay, now there's other disorders, hoarding. Okay, there's other obsessive related disorders such as hoarding. Um, Hoarding was previously considered a type of OCD. It's characterized by excessively collecting or keeping items regardless of their value. When you go to try and get them to disregard it, they always say, "Oh, I might need this one day," even though they never use it. Um, it causes distress and impairment because the house could come too cluttered, have a lot of arguments with family members. It's not considered OCD anymore, but it's considered a form. Hoarders are they need a lot of help. Um, they 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 can't even just to even think about cleaning out their stuff that they've been hoarding produces extreme frustration and anxiety for them. They usually cannot do it on their own and they need help to do it. You want them to be there present as they go through it because they need to feel that anxiety to get over it so they won't start hoarding again. But they will. Most likely, hoarders, even once you clean them out a couple times, they'll continue to do it. Okay, trichotillomania is hair pulling, or we can also have skin picking disorder. So trichotillomania is the urge to pull out one's own hair from anywhere on the body. It has to lead to notable hair loss in the eyebrows, arms, or pubic region. I know somebody who had struggled with trichotillomania when they started going through adolescence. It was a male, and as his legs became hairy, he was pulling them out. So now he's a grown male, and he has no hair from his knees down all the way. So his hair starts at right below his knees are hairy and all the way up his thighs. So but when he wears shorts, it looks like he has cleanly shaven legs and he has not one hair left. And that is the permanent damage of trichotillomania. Another one is the skin picking, which is repetitive and compulsive picking of the skin, leading to tissue damage. These people pick even though they don't really have much going on. They actually cause sores where they're picking. This is not related to drug use or anything. I know a person who has this disorder and they struggle. She wears a lot of makeup and is able to hold her sores or hide her sores, but it's it's very impairing on her, and she's aware that these people are aware they do it, but it's a compulsion. They cannot stop it. Body dysmorphic disorder we'll talk about really quick. It's a preoccupation. An individual has a preoccupation with some, here's the key word, imagined defect in appearance. Imagined. It is not real. So it's not like a burn victim who's concerned about their appearance or somebody who may have a really large nose. This is someone who has an imagined defect. They think their ears are too big or their muscles are too small or their skin is uneven or their breasts aren't big enough or their nose is too big. Some people may have an actual defect, but it's only slight and nobody would even barely notice, but they obsess upon it. Okay. It leads to significant distress and impairment. It leads to compulsive behaviors, like they'll be repeatedly mirror checking, going to the mirror constantly, looking at their cell phone and looking, putting on the camera and seeing what they look like. Or they may avoid mirrors altogether. It may cause them so much distress that they actually avoid hygiene. Like they'll brush their teeth and stuff, but they won't even look in the mirror and do basic grooming because they're afraid of what they see. Self-esteem is low, and suicide is high with this disorder, interestingly enough. So body dysmorphic disorder is going to be the preoccupation with someone thinking they have a defect in their appearance that they don't. Statistics, Very common, 1 to 2% of the general population, but it's actually approximately 4 to 28% of college students meet the criteria. So there could be someone in our class who's struggling with this disorder. It's equal among males and females. I know some of you are probably going to go, oh, this is a female disorder. Actually, incorrect. It's equally males and females. Many remain single because they're very insecure. Many seek out plastic surgeons. So these people who struggle with this, they don't go for psychological treatment. They go to medical doctors to get themselves altered. But remember, there was nothing wrong to begin with, and it doesn't cure the body dysmorphic. Therefore, they're still going to believe something's wrong with them, and they're going to continue to have surgery after surgery after surgery, because the problem isn't their physical appearance. Their problem is their psychological mind. It runs a lifelong chronic course if not addressed, and like I said, these people do not seek psychiatric or psychological treatment. They will stay in the medical field office. If we were to try and treat them, like I said, we're not going to see them. We could give them some SSRIs, which will decrease the kind of compulsions that go with it. We could do exposure, try to get them to not wear makeup, try to get them to look in the mirror if they want. If they're always checking the mirror, take away their mirror. It's kind of like that exposure prevention response that we did with OCD. So I want to end this quickly because your time is precious, and hopefully you got this far. Maybe you didn't. But anxiety and related disorders, this is like in general. So all the disorders we talked about occur when natural and adaptive processes, anxiety, fear, and panic, become disproportionate to the environment. Okay? These disorders occur as a result of biological vulnerabilities, generalized psychological vulnerabilities, and certain specific psychological vulnerabilities. So the cause is interdisciplinary. It's integrative. It's not just one thing. I do want to point out the smokers. Heavy smoking, nicotine. So that doesn't mean, I know I have up here that it has more than 20 cigarettes per day. But if someone is ingesting the equivalent amount of nicotine, it increases the likelihood of developing a lifelong anxiety disorder. So if you know somebody who's smoking or you're smoking, you may want to take that in consideration, especially if you already are feeling anxious. You may want to cut that down. Please note that nicotine is a stimulant and plays on your central nervous system. Okay, as we learned, in case you didn't see the trend, but the most effective treatment for most, not all, but most anxiety disorders is cognitive behavioral therapy. And once again, we say cognitive behavioral therapy, but as you notice, cognitive behavioral therapy would be a little different for each disorder. So understand what those nuances are. Medications may, I like the word may, also be helpful in treating anxiety disorders in the short term. So I want to thank you for taking the time and watching this video. I hope you find it helpful. Whether you realized or not, I did point out some significant things that you will see on an exam if you made it this far. And that's it. Thank you very much, and study hard.